Okay, so I guess we'll get started. I wanted to welcome everyone to the training on the role of nurses in recognizing and addressing oncologic emergencies in leukemia and lymphoma, syndrome of inappropriate antidiuretic hormone secretion, organized in partnership with Princess Margaret Cancer Center. Today, Matthew Somerset will address this third training in a series of 4. To get started, my name is Leslie Ann Guiney, and I am the Community Services Lead here at the LLSC for the East Side of Ontario. Since there are many of you in the audience, we would invite you to type all of your questions and comments into the Q&A box on your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I'll read some of them at the end of the presentation during the question and answer period. Today's training will be recorded so that you can watch it again on our continuing education platform. Before we begin the main presentation, I would like to share our mission and highlight some of our resources that might be helpful to you and the patients and caregivers you are supporting. Next slide, please. At the LLSC, our mission is to cure blood cancer and improve the quality of life of those touched by a blood cancer and their families. We offer a wide range of programs and services to help address the needs of the blood cancer community from coast to coast. Next slide. We offer a continuing education program that you can join free of charge. You can register to 1 or more trainings, and you can do it at your own pace and receive an electronic certificate of participation. They are all offered by experts. We have 1,000 healthcare professionals that are using the platform, and there are about 40 trainings available. The types of training that are available for you are trainings on blood cancer, treatments, psychosocial aspects of cancer, and more. For example, there are 2 first training courses offered in the series, Recognizing and Addressing Tumor Lysis Syndrome, presented by Graham Dozois, and Recognizing and Addressing DIC, presented by Cindy Murray. They are available on the Blood Cancer Continuing Education.ca or by using the QC code on your screen. Next slide. The community services leads from coast to coast that are available to support the blood cancer community. They listen attentively and with compassion to the challenges patients, survivors, and caregivers face, and can help assist the community to find information specific to the type of blood cancer they are living with, their treatment type, and anything else that they might need. We also aid in helping the community get organized to manage and take charge of their care, and we can identify services that would be beneficial for them. Visit bloodcancers.ca to find the contact information of the community services lead in your area. Next slide. Did you know that the LLSC has a smartphone app where your patients and caregivers can track symptoms and side effects and much more? This healthcare manager app is free to download and includes medication reminders, meal planners, medication, and side effects trackers. Plus, it can be shared with caregivers to access all of the information. The app is available for Apple and Android devices. Next slide. It is now time to introduce the speaker, Matthew Somerset. Matthew has been a nurse since 2005 and a nurse practitioner since 2016 in various roles. He is now working in the inpatient and outpatient leukemia at Princess Margaret Hospital. Over to you, Matthew.
Thank you so much for that introduction. We're going to talk about SIADH today, and we're going to go through it pretty quickly. This topic could probably take up an entire day, but we're going to go through it half an hour and do just a brief overview. Of course, many of the people that are in the room with me, you know how to get in contact with me, but please reach out for any questions that aren't answered in the question period. Next slide, please. So the objectives are pretty straightforward. Okay, we're going to do definitions. We're going to do all the stuff. The important point, I think, is that I want you guys to walk away with an intuitive understanding of what's going on here, so you don't have to memorize it. And so you can understand what is happening. Next slide, please. Definition: syndrome of inappropriate antidiuretic hormone secretion. So we already know from the term that something is wrong here. It's not just the inappropriate secretion, it's the inappropriate, also the ability to suppress the hormones. So both things are happening. It's also worth mentioning that there is times where ADH is appropriately on. Okay, next slide, please. It's a diagnosis of exclusion, so there's no way that we can send a test to diagnose this. Hyponatremia, low sodium, is going to be your first clue that something is up, okay? But not all cases of hyponatremia are going to be due to SIADH. We'll talk about that. Like you'll hear me repeat myself a lot during this presentation, and that's because I just want to hit home the key points. So yeah, please bear with me. The key, and I think the key here is that nurses have the biggest role. You, bedside nurses, point of care nurses, have the greatest role in recognizing this and helping us figure it out. And physical exam and history taking is key. That said, if you have a patient that you see hyponatremia in and it's prolonged and unexplained, don't hesitate to go to a provider or whoever and say, I think we need to involve endocrinology or renal subspecialty. Next slide, please. So why do we care about this? Okay, so why is this syndrome even a thing? So patients with malignancies, so that's every patient that we see here at Princess Margaret, is at higher risk just for having malignancy. They also have other things as a result of their malignancy and their treatment that put them at higher risk for this as well. We need to identify this early, and we'll see this as we go through the presentation about how to recognize this. The third point here is that the treatment of SIADH, first, you have to recognize it. And then second, you need to treat it appropriately. And there's ways to treat it that are dangerous. And we'll talk about this as well. Next slide, please. So before we kind of talk about the inappropriate secretion of ADH, by the way, ADH is also called vasopressin. So those of you that are listening that have worked in critical care areas, this will be a very common drug for you. But just so you know, those things are equivalent. So ADH, antidiuretic hormone. So our brain recognizes that there's less there's less water in our bloodstream, and it talks to the posterior pituitary, and then posterior pituitary talks to our kidneys, and it tells them to stop excreting water. Okay, so to reabsorb water. So our kidneys decide whether to reabsorb water or whether to excrete it. And then there's a feedback loop. Okay, so that's the normal functioning of ADH. Next slide, please. The basics. Okay, so what are you going to see on labs when this person has this condition? It's a syndrome. It's not a diagnosis, it's a syndrome. So hyponatremia, low sodium, serum hypoosmolality. So we're diluted. The blood is diluted. And the mnemonic that I use to remember this syndrome, and it has a sister that's outside the scope of this talk, is that you're soaked inside. SIADH, soaked inside. Okay, so your blood is diluted. Because your blood is diluted, your urine is hyper-concentrated. So you have hyperosmolality in the urine. And as a result, you have high urine sodium. So these are the things you guys are going to see. And then going back to the role, these are the things you're going to suggest to the provider. When you see a low sodium, you say, do you want to send urine? Do you want to add on an osmolality? Next slide, please. Okay, so I actually mislabeled this slide, and I wanted to change it yesterday, but it was too late. So causes aren't exactly the right term here. These are associations with this syndrome. So you can read them for yourself. So these are things that kind of come along with the syndrome of inappropriate antidiuretic hormone secretion. You guys can read them for yourself. So malignancy is like one of the big things, right? That's all the patients we see. All the patients we see have malignancy. Pulmonary disease, so they come along with like COPD. Some of our patients have HIV disease. And then certain drugs can cause this as well. So like we need to really involve our pharmacy colleagues to figure out whether this might be at play. Next slide, please. So this has been like, we've recognized this for a long time. So you can see 1967, that's a long time ago. The important point in this slide is that it's all the stuff that we've already talked about on labs. So hyponatremia, again, is going to be your first clue. We've talked about serum osmolality, we've talked about urine osmolality, we've talked about urine sodiums. I think the important point in this slide is that even though we're soaked inside, right, in this condition, they will look euvolemic on exam. So these are not puffy people. So you won't be able to recognize it on exam. Okay, they're not, they won't have swollen hands, they won't have swollen feet. Okay, next slide, please. All right, so I think the important point here is, and what I want to drive home is like, we have to go back to our basic science. And we have to understand that SIADH is a problem of tonicity. So does everyone remember that from their grade 9 or 10 chemistry? So let's go from the I guess the right to the left. So an isotonic solution is what we ideally want, homeostasis. In SIADH, we're in the middle pane. Okay, so there's more water than there is solute outside of the cell. And that's going to cause an influx of water into the cell. So you can see in this depiction that the cell starts to swell. Water is diffusing across the cell membrane into a cell. So you guys can imagine that this is not a great situation. And this is a cause of a number of the symptoms that we see. We'll get to the hypertonic solution in a little bit. Next slide, please. I know that's a lot of info to like hammer at you guys so early in the morning, but let's just summarize. SIADH is a fundamental problem of osmolality, so the amount of solute that's in the fluid surrounding the cell. Free water is being inappropriately reabsorbed by the kidneys. Okay, so remember, ADH is on inappropriately. So the kidneys are reabsorbing free water without solute and hyperconcentrating the urine. And then ADH remains on despite the osmolality. So there's like the feedback loop is not working properly. And this is why people have low serums. Next slide, please. Okay, let's go to a case. Let's contextualize this so we can kind of all understand. So Ms. C is a 76-year-old woman, recent diagnosis of AML. She is presenting to the infusion clinic, where some of our folks here that are with us in person work, and she's got a week of Azavet. Sound familiar, everyone? Yeah. So she had her blood draw, which she does, but then her partner kind of comes to the desk and says, like, she's not acting like herself. She's forgetting names. She seems confused, and she's sleeping longer. And then also, her urine kind of smells off. Is this raising any alarm bells for people? Yeah. All right. Next slide, please. All right. So these are some of the objective things that we do. Okay. So she's afebrile. Her BP is like maybe softish. Um, heart rate a little tacky. She's 93% on Brumaire. Her respirations are 20. And then this is her previous medical history. So she's got osteoarthritis. She has COPD, so maybe the oxygen sat isn't that surprising. She has a history of a colon polyp, and she has bipolar disorder. But it's well controlled, and she hasn't had any hospitalizations. Next slide, please. These are our initial labs. So hemoglobin, 58, not surprising, correct. Platelets, 20, also not surprising given her therapy that we're giving her for her leukemia. Neutrophils, 0.2, so she's neutropenic. The sodium is 123. Is this raising alarm bells for people? Yeah, exactly right. Great. And then the rest looks good. Next slide, please. We also do a chest x-ray because of her history of COPD. I pulled this off the internet, but you guys can see pretty clearly there's something going on, right? You guys see that thing in the right lower lobe? Yeah. We don't know, and so radiology is telling us it's either a mass or a consolidation. We don't know. To correlate clinically. Next slide, please. All right. So this person is really sick, right? So like, I don't think this person can hang out in our infusion clinic. I think we need to admit this person to the floor. Does anyone disagree? Yeah. We do a lot of stuff. Okay, so in this scenario, we admit them to the floor. Because of low sodium, and we don't know the cause yet, we decide to start them on NS at 100 cc's an hour, and then give them empiric antibiotics for maybe this right lower lobe infection. Still confused. Next slide, please. So what do we anticipate? Like, you guys are really smart. So like, these are some of the things that you guys would be asked to do. Blood cultures, even though they're afebrile, but they've gotten evidence of a potential pulmonary infection. Sputum samples or a BAL? That's a question. It depends how sick they are. A urine culture for sure. The important point here is that someone with a low sodium has to have a repeat lab. There is no circumstance under which someone with a sodium of 123 can just be like let out without having it repeated. And that's okay. If they're a well-appearing patient that's an outpatient, you want to do it, you want to repeat it quickly. And then we talked about the urine electrolytes, we talked about the serum osmolality, we talked about the urine osmolality, because that will help you define the syndrome. So these are the things. So I guess the take-home point from this slide is if the patient is going to the bathroom, no provider is going to slap your hand, so to speak, if you collect a urine and say, do you want me to send it for urine lights and all these other things. Thank you so much. Next slide. All right, so here are the repeat labs for Miss Sai. Her sodium has dropped. And so I put a high and a low. Don't memorize these numbers because the healthcare record system helps you know whether they're high or low. but her sodium has dropped from 123 to 119. Should raise your alarm bells. The rest of the thing, so her serum Oz is low. Which means that they're soaked inside. Urine Oz is high. Urine is getting hyper concentrated. And then the urine Oz, again, is high because the urine is getting hyper concentrated because the kidneys are saying, we need to take back fluid. That's what's happening. Next slide, please. Okay. So we have probably made the diagnosis of SIADH in this case. She has lots of risk factors. She has CNS disease. She has a malignancy. She's got an infection. And so what do we do about it? So what is our role here? Like, how do we deal with this? So recognize and treat reversible causes. So right off the bat, we think she has a pulmonary infection. So we're treating that appropriately with antibiotics. Her CNS disease and related to her bipolar disorder is well treated, so we can knock that off the list. And the malignancy we're treating with the azaven. Okay, fluid restriction. So this is the hallmark and the gold standard for treating SIADH. And I want to drive home the point that fluid restriction is so important because remember, the kidneys are retaining fluid inappropriately. Okay, so if we give them more fluid, it's going to worsen their hyponatremia, and then they're going to lead to seizure coma. So this is really important as nurses, I think, because first of all, we don't like to restrict people's fluids. If someone says, I'm thirsty, we usually like plop down, a graph or whatever of fluid, and just like, have at it. In this situation, we really need to restrict their fluids. Okay. And then do you remember how the sodium dropped from 123 to 119 despite normal saline at 100 cc's an hour? That is also your clue. If you give someone with SIADH normal saline, their sodium will drop because, again, the kidneys are reabsorbing fluid. There are other cases of hyponatremia that won't respond in this way, but if you see a sodium drop despite sodium replacement, that's good. Fluid restriction usually to 1.5 liters a day. And this is like, it's tough to do to your patients. Like, I don't like to tell people not to drink, but it's really important. Okay, so sodium replacement. So this comes in a number of flavors. Okay, so as we said, saline will worsen their normal saline, so 0.9% saline will worsen their hyponatremia. But we also have salt tabs. So you guys have probably seen someone on salt tabs, right? Well, yeah, some people. Okay. So yeah, sometimes we replace just with like salt tabs where they take it off. Sometimes diuretics can be helpful because it helps excrete free water, but not, I wouldn't reach for diuretics without getting someone else involved. So like renal or someone else. Yeah. And then there are ADH receptor antagonists, so things that will turn off that signal in the kidney to reabsorb free water. Those are very rare. I don't think you'll ever see them outside of an ICU. Next slide, please. Right. So here's our cautionary slide. Okay. So sodium replacement has to be done carefully. And then we saw this little graphic earlier before. And then our middle, so on the far right is our normal state. The middle pane is what happens in SIADH, right? So the free water is diffusing into the cell and swelling it. If we replace sodium too quickly, we get what happens on the left-hand side, which is cell shrinkage, right? Free water is being drawn out of the cell. And this can actually cause death. So I have this a general guideline. Serum sodium shouldn't be increased by more than 8 milliequivalents in a 24-hour period. So this is, again, why you guys are so important. Wherever you're working, you're like, wow, no, this sodium is increasing too quickly, and we're going to go to the left-hand side. Like, that's what we don't want. So I want to just highlight to the idea of hypertonic saline, which is 3% saline. Has anyone ever administered this? No. So good. It should not be administered, in my opinion, outside of an ICU. Because if it's administered too quickly and you don't really know what's going on with the patient, then it can be fatal. It'll cause demyelination. It'll cause demyelination syndrome, which is fatal. Next slide, please. Okay, let's just do a detour because I want everyone to kind of absorb this. What is a critical hyponatremia? So my temperature starts to rise when it's below 125. There are people that chronically live with hyponatremia, and that's okay. If it's below 120, I want you to repeat the lab as soon as possible. The quickest way to do this is via a venous blood gas, which does different ion measurement. Is more accurate, actually, than the ones that we send in the green tube. Yeah. So below 120, you call a provider and you repeat it. You don't even ask. Just repeat it. And then a critical sodium always has to be accompanied by a viscosity. So if someone is 119 and you're looking at them and you can't wake them up, that's a code medical, that's an access call, okay? Because something very bad is going on. If they're talking to you and they seem completely normal, repeat the lab. Okay. Next slide, please. Okay, so let's kind of summarize. You guys, as I said, are the most important people in helping to recognize and manage this. So recognize hyponatremia and use your history and great history and physical exam skills to kind of figure out what's going on. So if someone comes with hyponatremia, you say, have you been having diarrhea? Are you eating okay? What's going on? Have you been throwing up? These are all sort of things you guys regularly do. If the person is like, if you're concerned about the person neurologically, then you raise the alarm bell to a provider and we go from there. We talked about critical hyponatremia in the previous slide. So involve the appropriate healthcare team. So if you suspect SIADH, in the case of Miss Sai that we just saw, be alert to changes in the patient's condition. So as we saw at that like cellular level, these people can get quite sick very quickly because their brain can swell. So patient and family education is also really important, you guys. And this means like families are very well-meaning, but if they have a 1.5 fluid restriction, 1.5 liter fluid restriction, we need to be harsh. So it's like you can't bring in tea or whatever you want, and you can't go to the pantry and get them more fluid, right? Because it's going to worsen their hyponatremia. Replace sodium when appropriate, and that will depend on the patient condition, right? Whether we go to salt tabs, again, I don't like 3% saline would only be in a very safe setting. And I think the other thing too is, so the last point here is like for symptomatic patients, so patients that are like confused or they're not acting appropriately with a critical sodium, repeat it. If you have the ability to do a venous gas, I would recommend that. If not, then just send it via your lab. Next slide. I think that's it. Thank you. Thank you so much for bearing with me, and I'll take any questions.
Thank you so much, Matthew, for being here with us today. It doesn't look like we got too many questions during the presentation, so I will open it up to the room and ask if there's anybody in the room who has a question. If you do, just shout it out. And Matthew, would you please repeat the question before you answer it for us?
Absolutely. Yeah, so I'll just repeat the comment that the excellent comment made by Graham, one of our nurse educators. On the inpatient units, there's a multidisciplinary team, and it's important that we communicate with each other because fluid restriction is, again, the hallmark of treating this. And it's tough when you're working on a team and then a patient says, "I'm so thirsty, please give me more water." And people, even though there's a sign, which the point that Graham made, we really need to make sure that it's communicated across the board. I think, Graham, if you like, yeah. I'm getting the flavor. Okay. Yeah, and it's so. I mean, like we're all oriented in the same way. We're here for patient care, but like fluid restriction is the hallmark of this, the treatment of this syndrome. And if we don't do it, we could cause more harm. So it's really important that we are all on the same page.
Thanks, Matthew. So a question just popped up. It says, sorry, did you say fluid restriction to 1.5 liters? And do you have any more detail on salt tab dosage?
So no, it's a little bit, I have to say, like, it's a little bit of voodoo, to tell you the truth. So there's no hard and fast guidelines. People kind of do their own thing. Fluid restriction, like 1.5 is the standard. But again, this is a little bit of like, let's wait and see what happens. So they like if 1.5 isn't working, then we restrict them to 1 sort of thing. So we follow the sodiums. I think that's the most important thing, is that we follow the sodium. Yeah, and then like salt tab dosage, I don't think I've seen any evidence-based recommendations for it.
Okay, well, thank you again, Matthew. It was very informative. Explains quite a bit. So I will ask Pascal if you could move to the next slide. And I just want to ask if there's any other questions before we do that.
So the question was, how long does it take to correct the lab values with the appropriate treatment? I think that's, I don't think I have a good answer for that. Yeah, that's right. No. So like, again, the repeat sodiums are the repeat labs are what's important, because you want to make sure it's trending in the right direction. And then you change your therapy based on what the sodium levels are, and also like what the patient looks like. So if they're becoming more confused and more like altered, then it's time for sort of ICU level care where they can do a sodium every 2 hours. So I've seen that. I've seen a sodium every 1 hour. So obviously that's not something we can do in the outpatient setting. It's not something we can do even on our inpatient floors. So if a critical sodium with a patient that looks altered has to be at a higher level of care. And please do not hesitate to advocate for that.
Thank you for that. So I will invite you all to attend the next training in this series. It will be the fourth and final. It is on febrile neutropenia, and it is on Wednesday, December 13th, same time. And nurse practitioner Jane Lee and Melissa Lowe will be presenting. Next slide.
You guys are gonna, by the
Go
way,
ahead.
you guys are gonna love Jane.
Oh, thank you. We've really enjoyed all of the series, and it's been very, very informative, and we're very thankful that you guys have all pitched in and helped us bring this to our platform. So we will also be presenting live in January on the 23rd, the needs of transgender and gender diverse people in our healthcare system. That'll be presented by Dr. Stephanie Medill, Assistant Professor, School of Rehabilitation Science at the University of Saskatchewan. Next slide, please, Pascal. And finally, another event that could be of interest to some of you is patients and caregivers that you're supporting is a new treatment guideline for chronic lymphocytic leukemia on December 14th. Next slide. This event has been made possible thanks to the support of our partner AbbVie. And next slide. Finally, I would like to remind everyone that we are here for the blood cancer community. Do not hesitate to order our tear pads, which are free, and you can contact us if you need more information or support. Please note that a short survey will be sent to you all after the webcast, and we would greatly appreciate it if you would take the moment to fill it in and help us offer you the most valuable information in the near future. Thank you again for attending, and have a wonderful rest of your day.